And the issue is, as daratumumab now is really used up front, and is now, most recently looks like it will be fully approved for its use in high-risk smoldering myeloma. When you've got widespread use of CD38 monoclonal antibody therapy up front, what's its role in relapse? And I think it very much depends on treatment sequencing and treatment intervals, and whether or not at the time of relapse the particular patient in question is actually on a CD38 antibody. So I think bearing all of those factors in mind, certainly in our own practice, we've been exploring Isatuximab up front, and therefore using daratumumab in later relapse, and vice versa. For patients in our practice who receive daratumumab-based therapy early, what's the role for Isatuximab in relapse? And we're seeing important response signals, but I think one has to be careful about immediately following when say, for example, daratumumab-based therapy up front has failed a patient, then coming straight in with an Isatuximab-based platform. And I say that only because I think there are so many good other options. And so, for example, the use of a BCMA-based platform then followed thereafter by, say, an Isatuximab-based approach may make sense. At our own center, however, we're doing a very interesting study called ISABELA, led by my colleague Andy Yee, where we're combining Isatuximab, Belantamab, with Pomalidomide and Dexamethasone, a quadruplet of drugs. And we're using that, and you can have had prior daratumumab-based therapy, but our only requirement is that you're not actually refractory to daratumumab when you come onto the trial. Suffice to say, a number of my patients have participated in that trial. They've had prior daratumumab. Actually, I'm very pleased to say they've all responded, and they've tolerated treatment remarkably well. But that's obviously an integration of Pomalidomide, CD38 monoclonal antibody in the form of Isatuximab, and Belantamab mafodotin. So, really interesting approach to taking on initial treatment failure.